Welcome back, friends, once again. So, we are now going to talk about chronic obstructive pulmonary disease or COPD. Well, this is also referred to as chronic obstructive lung disease or chronic obstructive airway disease, that is COLD and COAD. These are the short forms often used in the clinics by the doctors, so they are synonymous with COPD. Well, this is characterized by chronically poor airflow. It gets worse over the time, and chronic, incompletely reversible poor airflow characterizes COPD along with air trapping, that is, an inability to breathe out fully the inhaled air. So, there will be a limitation to the airflow, that means there will be a reversible poor airflow along with an inability to breathe out the air which has been inhaled. So, two factors or 2 points which characterize COPD are: first is airflow limitation, and second is air trapping. So, the main symptoms include shortness of breath, cough, and sputum production. So, here is an X-ray where you can see that there is enlargement of the lung spaces here, or there are cavities seen in the lungs all across. Well, on the left lung you can see the bronchial markings. Well, this is fairly normal, but the left lung has lot of trapped air inside along with cavity formation. So we'll talk about this condition later. I will get back to you once again with this X-ray. Well, most people with chronic bronchitis have COPD. Tobacco smoking is the most common cause, along with air pollution and genetics, for development of COPD. Long-term exposure to these irritants cause an inflammatory response in the lungs, resulting in breakdown of the lung tissues known as emphysema and small airway narrowing known as obstructive bronchiolitis. So we have limitations of airflow and we have trapped air or air trapping, where emphysema is actually air cavities inside your lungs, and obstructive bronchiolitis, this accounts for the limitation of the airflow. Well, severe destruction of small airways can lead to formation of air pockets known as bullae that replace the lung tissue. So we go back to the X-ray and see the bullae here. So they are basically the air cavities or the air pockets. Once again, I will highlight you. So these are the bullae which are formed, and that replace the normal lung tissue. Well, this form of disease is called as bullous emphysema. So air pockets are known as bullae, and the disease is called as bullous emphysema. The narrowing or the limitation of airflow is due to obstructive bronchiolitis, and limitation of airflow is due to emphysema, and air trapping is due to emphysema, to be precise, and obstructive bronchiolitis leads to a condition called as airflow limitation. So emphysema will lead to is due to air trapping, and airflow limitation is due to obstructive bronchiolitis. So I repeat again and again because it is confusing at times, because so many new terms are coming ahead of you. So just to do a recap, emphysema is basically the breakdown of the lung tissue, and it is called as bullous emphysema when there are air pockets or there are air cavities inside your lung tissue, or the lung tissue is replaced by these air pockets, and this form of disease is called as bullous emphysema. So we go on to the next slide. Well, now, narrowing of the airways occurs due to inflammation and scarring within them. This contributes to the inability of the person to breathe out the inhaled air completely. So this results in the reduction in the airflow while breathing out. Well, the more air from the previous breath is held inside the lung because the person is unable to breathe out, and this causes an increase in the total volume of air inside the lungs at any given time. So this process is called as hyperinflation or air trapping. So that means their lungs are filled with normally more amount of air than which they are capable of. The diagnosis is based on poor airflow as measured by the LFTs, that is your lung function test. Well, in contrast to asthma, the airflow reduction does not improve significantly with the administration of medications. So if you give a bronchodilator, then probably there won't be much significant improvement as it would have been in the case of a person suffering from asthma. So what are the tests? So we talk about spirometry. Well, spirometry is a test which measures the amount of airflow obstruction present and is generally carried out after the use of a bronchodilator, a medication to open up your medication to open up your airways. Well, it has got two components. First is FEV1 and the second is FVC. Well, FEV1 is forced expiratory volume in 1 second, which is the greatest volume of the air that can be breathed out in the first second of a breath. Well, forced vital capacity is the greatest volume of air that can be breathed out in a single large breath. So in 1 second it is called as the amount of air what you breathe out is in 1 second is basically FEV1, and FVC is the total amount of the air which you breathe out in a single large breath. So normally 75 to 80% of FVC, that is forced vital capacity, comes out in the first second, and FEV1 upon FVC ratio of less than 70% is someone with symptoms of COPD defines a person as having the disease. So we come to know about the COPD or its limitations to the airflow with the help of spirometry. Well, we now move on to the next disease, which is called as bronchial asthma. But before moving on to it, we have to have a slight bit of a little more on spirometry. I would like to explain. Well, a peak expiratory flow is again a measurement unit. Well, this is the maximum speed of expiration and is used in asthma, but it is not sufficient for diagnosis of COPD. Well, spirometry may help to determine the severity of airflow limitations. This is typically based on FEV1 expressed as percentage of the predicted normal for the person's age, gender, height and weight. So if we go on to the next slide, which is talks about the bronchial asthma, we will come to understand the difference between the two. Well, asthma is a chronic inflammatory disease with reversible airflow obstruction and bronchospasm. So there is an element of reversible airflow obstruction along with a spasm. Well, common symptoms include wheezing, coughing, chest tightness and shortness of breath. It is clinically classified according to the frequency of symptoms, FEV1, that is forced expiratory volume in 1 second, and peak expiratory flow rates. Asthma may also be classified as atopic, that is extrinsic, or non-atopic, that is intrinsic, where atopy refers to a predisposition towards developing type 1 hypersensitivity reactions. Well, asthma has got recurrent episodes of coughing, wheezing, shortness of breath, chest tightness. Sputum may be produced by the lungs by coughing, but it is often hard to bring up. During recovery from an attack, it may appear pus-like due to high levels of WBC cells called as eosinophils. Symptoms are usually worst at night and in early mornings or in response to exercise or cold air, where it can be associated with GERD, that is gastroesophageal reflux disease, rhinosinusitis, obstructive sleep apneas and psychological disorders. So these are the associated conditions along with asthma. Well, when a triad, that means 3 diagnoses or 3 diseases are simultaneously present, then it is called as atopy. A triad of atopic eczema, which is a skin condition, then allergic rhinitis affects your nose, and asthma affects your lung, is called as atopy. So atopic eczema, allergic rhinitis and asthma contribute to a triad, and that is called as atopy. There is a correlation between obesity and asthma too. Well, cardioselective beta blockers appear safe in those with mild or moderate disease. Other medications that can cause problems or who can cause an episode of asthma in patients are commonly the non-steroidal anti-inflammatory drugs, the aspirins, and the ACE inhibitors. So we have to be careful while prescribing these medications to patients who have chronic or bronchial asthma, or are patients who have a triad of atopic eczema, allergic rhinitis, and asthma. So we have to be careful while prescribing these patients the mentioned drugs. Though cardioselective beta blockers can be given safely in mild to moderate disease forms. Now, what is the place of beta blockers in the therapy? Well, suggested medications for treatment of hypertension in presence of certain medical conditions. They can be given in CA, the coronary artery disease, post-MI, systolic heart failures, diastolic heart failures. Then they can be also prescribed in diabetes, in kidney diseases with limitations, stroke and TIA. Well, it is not at the moment not recommended. Then, well, there are a lot many drugs. Well, these two we don't include, like the kidneys, strokes, and the TIA. We are not prescribing. They are not the suggested medications for treatment of hypertension. Well, yes, for diabetes, yes. For diastolic heart failure, yes. Systolic heart failure, yes. Chronic artery disease, yes. Post-MI, yes. So now we will talk about the beta blockers. What are the beta blockers, and what is the mechanism of action? How many types of beta blockers are there? So we'll talk about all in detail now. Well, these are the drugs that block the beta receptors and are used to treat conditions like hypertension, angina pectoris, congestive heart failure, and arrhythmias. Well, beta receptors which are present in the body, well, in the heart we have both the beta 1 and the beta 2, and when they are stimulated, here we are talking about the stimulation. We are not talking about the drug. We are talking about what happens when the beta receptors are stimulated in our body and not inhibited or blocked. So this will be just opposite or reverse when they are blocked. So when the heart beta or beta 1 receptors, when they are stimulated, they increase the heart rate, contractility, and atrioventricular conduction. So blockers will do the reverse. Then metabolic effects, they have got it on basically on the beta 2 receptors. They cause hypokalemia, they cause glycogenolysis, they cause lipolysis. So these are the three effects which are commonly seen after stimulation of beta 2 receptors. Well, in kidneys they increase the renin. Well, in the bronchi, the beta 2 receptors, in the blood vessels you have the beta 2 receptors, and the skeletal muscles you have the beta 2 receptors. Well, what we see here is in the skeletal muscles the stimulation causes tremors, whereas in the blood vessels and in the bronchi the muscle tone is reduced, so or it is decreased, so there will be a dilatation. So when you block them, or when you block, the muscle tone will increase and they will cause bronchospasm or bronchoconstriction, as well as in the blood vessels they will cause vasoconstriction. So when they are stimulated, they reduce the muscle tone of the bronchi and the blood vessels, whereas when they are blocked, they increase the muscle tone in the bronchi and the blood vessels. Now, how are the beta blockers classified? Well, they can be classified as selective beta blockers and non-selective beta blockers. Well, beta blockers with additional alpha blocking effect.